Good afternoon, everyone. I'll be speaking on history taking and clinical examination. Following are the complaints with which a patient with retinal diseases may present to you: loss of central vision, altered color vision, distorted vision, diminished fine vision, central scotoma, diminished peripheral field, poor night vision, poor dark adaptation, flashes of light, floaters, and leukocoria. The most important of this are flashes and floaters. Flashes or photopsia are caused by stimulus of vitreoretinal traction on the retina. Acute PVD or posterior vitreous detachment is associated with sudden onset of flashes and floaters. Floaters are caused by vitreous opacity such as blood, collagen fibrils causing shadows on the retina. A patient presenting with sudden onset of flashes and floaters needs urgent retinal examination. Metamorphopsia is a symptom in which the objects appear altered with an irregular contour. It is seen in age-related macular degeneration, CSR, diabetic macular edema, and macular hole. Night blindness is seen mainly in vitamin A deficiency and retinitis pigmentosa. Color blindness is seen in genetic disorders, optic neuritis, and macular. Coming on to fundus examination. What is fundus? It is the visible part of the retina. It comprises of the optic nerve, vitreous, choroid, and retinal blood vessels. Why are the retinal blood vessels important? Because they reflect the condition of vessels of same size as were in the body, in the brain, heart, and kidney, and so they are of great prognostic value. The various methods of fundoscopy are direct ophthalmoscopy, indirect ophthalmoscopy, and slit length examination by the ruby lens, the plus 68 diopter lens, plus 90 diopter lens, Goldman 3 mirror, and pan fundoscopy. Direct ophthalmoscopy uses the optics of the eye under observation. Illuminated retina acts as an object and dioptric system of the eye. Direct ophthalmoscopy uses the optics of the eye under observation. The illuminated retina acts as an object and dioptric system of the eye as a magnifying lens of plus 60D in the metropic eye. An erect magnified virtual image is produced on the same side as object with a magnification of 15 times. How do you do a direct ophthalmoscopy examination? The patient is asked to fixate on a distant point with both eyes open. To examine the right eye, stand on the right side of the patient with the scope in the right hand and use your right eye, vice versa for the left eye. Ask the patient to move the eye as instructed to visualize the peripheral areas. Indirect ophthalmoscopy. The illuminated retina acts as the object and its image is formed in space after it passes through the condensing lens. The lens condenses the rays and at the anterior focal point of the eye, just behind the iris, and forms an image of retina in space between the lens and observer. A real, inverted, magnified, and laterally reversed image. First of all, explain the procedure to the patient. He is instructed to keep both eyes open. Start with minimal illumination and gradually increase the intensity. Adjust the headpiece comfortably and confirm your interpupillary distance. The lens is held between the thumb and forefinger of the left hand with the convex surface towards the examiner. The lens is brought closer to the eye till a good retinal glow is visualized. The lens is gradually withdrawn from the eye till the retina comes into focus. A strict protocol of examination should be followed. The right hand is kept free for fundus drawing and scleral depression if needed. The international code of color and symbols should be followed. You can see here the international color code of colors and symbols. Why do you need to follow this? Because when you examine the patient on follow-up, or even if you get a patient who is seen previously elsewhere, anywhere in the world, and he has his OPD case paper with a fundus drawing in it, then you can see what was the previous condition of the patient's eye. Scleral depression. It makes viewing of the ora and the pars plana easier. It allows the retina to be viewed at various angles. The depressor is positioned over the globe and light pressure is applied directly over the area of retina to be examined. The depressor is moved circumferentially or meridionally for dynamic viewing. Pulse for indirect ophthalmoscopy. It is best done with the patient in the supine position, best with maximum mydriasis in a darkened room. Lens should be tried to be kept parallel to the iris plane at all times. Troublesome reflexes from cornea and IOL can be eliminated by slight tilting of the lens. Observer should position himself away from the site of the suspected lesion and ask the patient to look towards the very important point, both pupils should be dilated and both eyes should be examined for comparison as a rule unless contraindicated at the first visit. This table explains the pros and cons of direct vis-a-vis indirect ophthalmoscopy. Direct ophthalmoscopy has the advantage of a 15 times image magnification and an erect image, and the disadvantage is that there is no stereopsis, the retinal periphery is not seen, the working distance is very short and indentation is not possible. Versus indirect ophthalmoscopy gives an inverted magnified image of 1 to 4 times magnification. There is good stereopsis, you can see the periphery with an indentation and you have a longer working distance. Coming to slit lamp biomicroscopy, the optics of the eye are modified by various lenses to form an image that is focused by the biomicroscope. High quality, highly magnified and three-dimensional view of the disc and the macula can be obtained. Fine changes in the posterior part of the vitreous, retina and optic disc can be studied binocularly with high magnification. The lens is held close to the eye between the thumb and forefinger. Illumination and observation arms of the slit lamp are aligned. Low magnification, low illumination, 2 to 3 mm with beam, and the slit lamp is withdrawn from the eye. Once the fundal glow is seen, the lens is withdrawn till the posterior fundus comes in focus. Plus 60, plus 78 and plus 90 diopter lenses form image that is inverted laterally and vertically. Ruby lens forms an erect virtual image. Goldman lenses produced erect virtual images. Normal fundus. The neurosensory retina is transparent. The background color is provided by the retinal pigment epithelium and vascular choroid. The fundus appears as uniform red with delicate punctate stippling towards the periphery. The optic disc is 1.5 mm in diameter, pale pink in color with well-defined margins. The central vessels emerge from a funnel-shaped depression which is the physiological cup. The following points are noted while examining the optic disc: the size of the disc, size of the cup, cup to disc ratio, width of the neuroretinal rim, presence of any notching, position of blood vessels, any new blood vessels, vascular pulsations and splinter hemorrhages at the. The macula is the lutea is situated 2 disc diameter temporal to the optic disc. The central 1.5 mm is termed the fovea. A small depression in its center, which is 0.35 mm in diameter, is termed the foveola. The foveal reflex is seen as an intensely bright spot of light in the center, and the foveal avascular zone is around 0.8 mm in diameter at the center, where there are no retinal blood vessels. The retinal vessels are derived from the central retinal artery and vein. They divide into two branches at or near the surface of the disc into superior and inferior trunk, and each trunk divides into nasal and temporal arteries and veins, which further divide into numerous branches. There are no anastomosis between the vessels. Arteries are brighter red and narrower. Veins have a purplish tint and are more convoluted. A bright silvery streak running down the center is more prominent in arteries. It is seen due to reflection of light from convex cylindrical surface of vessels. The normal ratio of caliber of artery to vein is 2:3. Normally, no pulsations are seen in retinal arteries. In 80 to 90% of individuals, retinal venous pulsations are visible at or near the edge of the disc. Normally, choroidal vessels cannot be seen. They are broad and ribbon-like. The central streak is absent. They anastomose freely, and they are seen to be separated by deeply pigmented polygonal areas, giving the so-called tessellated. Red-free light enhances the visibility of hemorrhages and blood vessels. Defects in the nerve fiber layer can be seen as slits or wedges fanning up or down from the optic nerve. The equator is considered to lie in line with the exit of the four vortex veins. The retina posterior to it is the posterior pole, and the peripheral retina is the area bounded by the ora serrata and the equator. We will see a few common fundus findings. One of them is retinal capillary microaneurysms. They are the first sign of diabetic retinopathy, appear as a dark red spot which hyalinize to form yellow or white spot. They disappear due to progressive hyalinization or occlusion of vessel from and take a few months to years. They are seen in central retinal vein occlusion, branch retinal vein occlusion, and hypertensive retinopathy apart from diabetic retinopathy. Retinal hemorrhages are of two types, dot and blot and flame-shaped. Dot and blot hemorrhages are deep hemorrhages seen mostly at the posterior pole, associated with hard exudates and mainly seen in diabetic retinopathy. They get absorbed within 6 to 8 weeks. Flame-shaped hemorrhages are superficial hemorrhages in the nerve fiber layer associated with soft exudates and seen in CRVO, BRVO, Eales disease, Coats disease, hypertensive retinopathy, among a few causes. Exudates can be hard exudates or cotton wool spots. Hard exudates are small with clear-cut border, waxy yellow in color and round shape. They are in the deeper layers of retina and occur due to leakage of serum, protein and fibrin. Cotton wool spots are present in the nerve fiber layer. They occur due to exoplasmic stasis due to ischemia, and they are mainly seen in hypertensive retinopathy, CRVO, BRVO, Eales disease, Coats disease, and retinitis. Retinal new vessels. Fine new vessels are devoid of connective tissue. They develop in the plane of retina and vitreous. Either they regress or there is condensation of connective tissue around the vessels, which may remain for 1 or 2 years. New vessels may regress with formation of connective tissue band and sheets, leading to tractional RD and vitreous hemorrhage. New vessels can be seen in diabetic retinopathy, CRVO, BRVO, Eales disease and Coats disease. Hard exudates, as we have seen, lie in the deeper layers of the retina, while drusenes are a yellowish deposit which are lying deep to the retina. You can see it as RPE elevations. Choroidal neovascular membrane is a neovascular sprout which grows under or through the RPE via break in the Brooks membrane. Sub-RPE CNVM is seen as a grey-green or pinkish-yellow, slightly elevated lesion. It may form a subretinal halo or pigmented plaque. Leakage from the membrane may result in hemorrhage, serous retinal elevation, or subretinal hard exudates. Most common causes are age-related macular degeneration, high myopia, angioid sticks, choroidal rupture, and polypoidal choroidal vasculitis. These are few examples of a choroidal neovascular membrane. So your take-home message is daily see fundus of at least 10 patients, and proficiency in indirect ophthalmoscopy takes practice, practice and more practice. Stay safe. Thank you.